Howdy, I'm Scott Lindberg. I'm the Director of Liver Transplant Anesthesia at Houston Methodist Hospital, Houston, Texas. We've been using the HotDog warming system now for about a year and a half. And we got to where we are today because our prior solutions for patient warming proved inadequate on pretty much routinely. Prior to using the HotDog, we utilized bear hugger, forced air warming. We used multiple different solutions: underbody, lower body, and upper body, and in combination, and sometimes as many as 3 machines on one patient. But we failed to consistently achieve adequate warming. Even in the best case scenario, when we did all the right things, we ended up with suboptimal body temperatures, intra-op and at time of reperfusion, and additionally, by the time we got to the ICU, we still hadn't recovered adequately, regardless of using up to 3 machines to warm. In our population, we had a fair degree of restriction on the body surface area that we were allowed to warm. Our program consistently utilizes vena-venous bypass with cut downs in the femoral and the left subclavian. So our body surface area available to warm using forced air was restricted substantially. We tried utilizing the underbodies, and that really would prove to be ineffective as well. Since moving to the HotDog system, we've achieved consistent and excellent results, often having to turn the heaters off towards the end of the case because the patients became too warm. Something I never achieved, even in the best cases, with forced air warming. Well, in liver transplant, it's very difficult to assign, outcomes to any one individual thing, but we have noticed with improved warming, you can definitely associate that with decreased rate of malignant arrhythmias during reperfusion or prior to reperfusion. We've had several malignant arrhythmias that were precipitated by hypothermia in patients with low magnesium levels, and the liver transplantation, liver failure patients often have prolonged QTCs at baseline, which puts them at risk of torsades. And in patients who have hypothermia, that risk is increased. And we have seen that in patients who are hypothermic, and we've not seen that with patients who maintain their normothermia. Infectious risks are, a very complicated question. I think it's imperative that we maintain warming because it has been shown to decrease wound site infections by avoiding hypothermia. But teasing out, I have not done the assessment to tease out that difference, whether prior to, pre versus post this new process. We've decreased infectious risks. That's always our number one concern. Looking at post-transplant mortality, infectious risks are routinely the number one cause of mortality in transplant recipients. That was a huge driver in moving towards a HotDog as our warming solution. It's still imperative that you pay attention to details, and pre-warming is imperative in this and any population, and then attention to detail after coming into the room and avoiding long periods of time where there's no active warming is essential. While placing lines, it's essential that we make sure that we're warming in that interval. We don't prep prior to surgeons being available in the room, and once we prep, we make sure that we initiate warming from the get-go. this is available to us now with the introduction of HotDog, because prior to that, once we started prepping, we had to turn the forced air warmers off. With forced air warming, we had a break in our ability to warm patients from the time we started prepping until after the drapes were up, for fear of, contamination of the field with the forced air warming. With the HotDog, we're able to actually place the warming devices in the position we want them for the entire case and activate them without a break at all and maintain warming through the period of time, prepping, draping, and straight through to the end of the case with no break. We found that there are several tricks to improving the efficiency of the warming device using HotDog. As any warming device, the important factors are the body surface area that's covered by the device, the temperature of the device, and the coefficient of heat transfer from the device to the patient. A lot of those things are not modifiable at the end user stage, but we have the big key points are to collaborate with your surgical colleagues to ensure that you are covering the greatest degree of body surface area that you can. Some small techniques that we found useful is make sure that the blankets are in good opposition to the patient. The heat transfer afforded by contact is greater than that through convective transfer through the air. So make sure that you have good opposition of the blankets to the patient. That the underbody is well positioned to be, not extending past the shoulders. You have the shoulders down. This is actually the setup that we utilize in my operating room. We have the underbody warming mattress, the lower body warming blanket, and the multi-position warming blanket for the arms. In a liver transplant, at my institution, we actually have a more restricted access to the patient, requiring access to the anterior chest wall. So we position more like this. This blanket cheated down a little bit here, but so this is a similar situation we'd have in our operating room. But the beauty of these multi-position blankets is they produce a great deal of functionality, and even if you don't have the arm axis, this can be actually utilized on the head. It can be utilized on the arms. The more body surface area you can cover, the more effective it's going to be. So if you can bring these up onto the chest and get better coverage on the chest, you're going to get a better effect. But we've achieved good results the way I showed you just a minute ago. We utilize Megadyne pads for grounding solutions. We actually place the HotDog on top of the Megadyne pad. The Megadyne pad is then restricted to just the mid-thigh down, and actually we've never had an issue with connections to the Megadyne pad with the HotDog on top of it. Routinely we monitor core temperature through bladder temp and blood temp. Occasionally, if we're doing a combined liver-kidney transplant, we don't have bladder temps, and so in those cases we'll monitor blood temp and nasopharyngeal temps. In my institution, it's been my experience, the liver transplant case has been the most difficult case to achieve consistent and reliable normothermia in, and to this date the only product that has reliably produced normothermic conditions pre-incision and hepatic and on discharge to the ICU has been the HotDog warming blanket.